Hello and welcome to another episode of Essential Implementation. What do NHS executives think about implementation? Well, my guest today has 37 years experience as a registered nurse and for the past 15 years has been involved in managing and shaping healthcare services. David Melia is currently the executive nurse and deputy chief executive for Mid Yorkshire Hospitals NHS Trust. And I wanted to ask him what his experiences of implementation have been. Hello, David. Welcome to another episode of Essential Implementation. So, David, with somebody with your level of clinical experience, who's now in a sort of a slightly different position of that exec, what would be really useful is to perhaps is to talk about something that you've been trying to implement. Obviously, with COVID, I'm sure there's lots of things. I had just a few things I wrote down: discharge to assess policy or flow issues. The implementation of hot and cold zones. I don't know if that's anything, any of those you've kind of been involved in and you might just like to comment.
Yeah. I mean, actually, in this last week, in this last 10 days, I have been involved in quite a big piece of work around the number of medically optimized patients who are fit for discharge. Horrible term, but that's what we all use. Who don't need to be in hospital, but for whatever reason, they're still with us. And these patients would normally either be being cared for in their own homes, either by relatives, unpaid carers, or a more formal care arrangement, or would be in a care or nursing home. But for whatever reason, they've not been able to get out of hospital. And so that's something that happens all over the NHS. But what we've noticed in Mid Yorks in this last period of time, this last couple of months, in the second wave of COVID, is that they've been of a number of around 80 to 100 people at any one point. So that's potentially 3 wards full of patients who don't need to be in our hospital. And that's not good for them, because the longer people stay in hospital, the more likely they are to fall or to get an infection or decompensate their ability to be mobile and self-caring, or lose muscle mass and those sort of things. But it's also using a really important resource of staffing that we need in other areas of the organisation to care for those COVID positive patients and other patients that are on site. So we've done a big piece of work this week around how are we going to work with our system partners to really get those patients appropriately moved into an appropriate place of care. And it frustrates me because we do this and then it slides back in to a problem and then we do it again. And so it's been really great this week. We've made fantastic movements. Our partners have been really supportive. But in the back of my head, I know that it's going to slip again, either because we're not doing our processes properly and we're not managing those patients appropriately, or our partners have a different set of objectives or a different pressure in front of them. And so we all take our eye off the ball, and it's not great care for patients. This week, it's been great care for patients.
Yeah.
But the secret is, how are we going to make it stick?
Yeah, to keep a change in place. And you talk about partners. Who do you mean exactly when you say that?
So local authority, our commissioning colleagues, primary care, some different agencies. So whether it's third sector, they're primarily the groups that we work with.
Yeah, it's so interesting to get this perspective, because you're kind of way up, overlooking all of this, making those decisions and then trying to get them in place. And most of the time I'm talking to clinicians and nurses and people literally on the ground with that. And I mean, my feeling is sometimes the communication is difficult. I just wonder, do you find there are issues, kind of like you might bring in a policy like this, but then for the actual clinicians on the ground to kind of really implement it, they find it difficult, to actually, I mean, in this case, to get someone out of the hospital sooner might be quite a challenge to them. I mean,
Absolutely. So I'll give you a for instance that really illustrates that.
Yeah.
So, like many organisations, we're a large organisation. We've got about 1,100 beds, 9,000 members of staff,
Mm.
work over two different communities, two different boroughs who have two different local authorities. And so to get patients out safely to be assessed so they can go into a care home in one organisation, one local authority. We have this trusted assessor model that it's about 3 or 4 steps. Pass all those steps, and the patient then moves on.
Mm.
The other, looking after exactly the same type of patients, and these patients might actually only live a couple of roads apart because the boroughs butt onto each other. There's about another 4 or 5 different steps around checking an authorization and checking an authorization. And there's an opportunity at each of those additional steps for the patient to go back to square one. And so that's incredibly frustrating. And so I don't understand why that's the case. And so how our frontline clinicians will understand that as well.
Right.
And I understand why both organisations have their own process, but we're in the same county.
Mm-hmm.
We're not talking about a different country or even a different county. Why they can't have a similar and joint approach, and that's just them within the organisation. I know that we've probably got some variation in practice and understanding in the way in which we work, and so that variation is always going to be the issue that causes delay, waste, in this case time, and time of the process, but also time of the clinician, and that's the biggest resource really that we need to recapture.
Yeah, so it almost sounds like you've got to you're sort of describing really that the system in its entirety is so big and so complicated, and actually also there's variation, and it's actually quite hard to avoid that variation sometimes. Yeah,
absolutely, and because we're not even talking about one organisation talking to another organisation that work within the NHS. We may be talking to one organisation, the NHS talking to local authority, that come from a different position and have different processes. So even that variation and even sometimes professional backgrounds, we don't always talk the same language.
No. Yes, I have to say that's come across a bit. I spoke to an ICU consultant not so long ago, and also some of the other clinical staff, and you do hear that sometimes just there seem to be different languages sometimes between people making the decisions and policies and the actual clinicians, and I certainly I don't want to sort of create a kind of us v them thing at all. I want to try to just really understand your perspective, and how.
And sometimes we take comfort in that, don't we? And being a nurse, I know that when I go out onto the clinical areas and I go onto a ward, and I can go to the nurse in charge on a general medical ward and say, "Hi, how are you? How's the ward today?" And they go, "David, you know what? It's really heavy today."
Yeah.
And so I can look around and think, well, I know what you mean on a medical ward. Your patients are really dependent. They need a lot of people to help support them and manage them and assist them. I can go to an orthopedic ward or a gastro surgical ward and ask the same question. They go, "It's really heavy today." And I will automatically switch into, you've got a lot of post-op patients, a lot of observations, probably a lot of IVs to do. And I can understand that because that's my tribe.
Yeah.
But if you get somebody from a different tribe coming in and they go, "The ward's really heavy," you think, you've got 4 walls and a floor and lots of beds. Of course it's going to be heavy. But it's we don't always help ourselves by excluding other people by the use of our language.
Because of your clinical experience, you are going in there as someone who understands that tribe, aren't you? And but you're actually in a different.
I'm only doing what other directors of nursing and other senior nurses and other senior clinicians do.
Okay.
That's why we have senior clinicians on a trust board, so that we can do that interpretation of event and circumstance, and then hopefully try and translate that into a picture, whether it's numbers or words, that has a wider context and understanding, so that as a unitary board, we can all understand and then make a decision.
Okay. What in your sort of experience then are the biggest obstacles to kind of getting a new policies and interventions in place?
To actually have them implemented.
Yeah, and so they're in and they're doing well, and then they sort of stay there. I mean,
yeah. So I think that if I don't say the number one thing is having a sustainable and motivated workforce, I think that anybody who watches this who's in a nursing profession would lynch me, because because that's what we do. No, it's we know that if we don't have consistency and continuity of care on a ward, that patients don't get the best level of treatments and service. And equally, if we don't have an able and fulfilled workforce, both fulfilled in numbers and in development, personal development, they're never going to have enough time or capacity to be able to really understand what the processes are about, and so how they can contribute to making things better, or complying and demonstrating the actions that are required to provide that great care for a patient. If you've got a large ward, and some of the wards here are 42 beds, if you've got a large ward and you're a staff nurse and you are caring for 8-10 patients, and you're down a couple of members of staff, you really don't have the bandwidth to do anything other than keep those patients safe, hydrated, free from pain, clean, tidy, and fed. And so if we are able to have a more sustained and fulfilled workforce and bridge that gap between vacancy and retention, that has to be one of the most significant impacts that we can make to improve quality.
Yeah, that's.
It's not the only thing. It's certainly not the only thing, because we then need to make sure that what colleagues we have that opportunity to learn and and develop themselves, but also take that opportunity to take a step back and look at their practice within their area to think, how can we do this differently? Because they're the experts on what needs to be better.
Yeah, I totally agree with that. I my role is about helping people implement things, but I always feel that the people in the context, it's a two-way process. I never go in there and say, you need to do this. I may say diagnose the context as a problem maybe being relative priority, which is this, like, it's not being kept a priority, whatever the new intervention is. But it's down to those nurses and the matron and the people on that ward to come up with all the micro strategies to actually overcome that problem. And I think the more receptive that team is, and the more I can relate with them, and then the higher the chance of them overcoming the issues and keeping that new intervention in place and a priority going forward. Without that, you can't do much, can you?
No, and sometimes I think that we as senior leaders don't always let people know that they have the authority to be able to make change. And so going back 150 years, when I was a ward manager, when everything was black and white, I had a ward. My background is neurology and neurosurgery, and I had a ward, and life was very different then. But looking back, some of the things we would be doing stuff day in, day out. And I remember sort of you'd be in the treatment room or the sluice, or you'd be making beds or whatever, and you'd have a member of staff with you, and you'd talk about this, that, and the other. And you'd talk about something that really, really irritated you on the ward. And you'd work out, well, perhaps if we tried, and basically what we were doing, we were doing a PDSA cycle, but we didn't actually call it a PDSA cycle. We thought, well, we'll just have a go at trying something else. And we would have a little bit of a trial, and we'd talk at handover and say, we want to get the discharge medication, or we want to get patients take home medications. It takes forever. What can we do to make it better? Because we know that on a Friday afternoon it's carnage, and people get really upset because they want to get home before tea time. What can we? And so we just sort of talk through, well, perhaps if we got the drugs organised the night before, and because we knew they were going home. And so basically we did lots of like small PDSA cycles, but we never measured it really. We never counted it, but actually we were doing that plan, do, study, act. And that's what we were doing. And I think sometimes colleagues who are on the front line, they don't have the time to think that, but sometimes they don't think that they have the authority to be able to make that change. And partly that is the responsibility of people like myself to really get people to understand. If you're a ward manager or you're a ward member of staff and you've got a great idea for how things could be better, just give it a go. Talk about it. Have a think about it. And if you need some assistance, we've got people who can come and help you if you want to formalize it. But
that's fantastic. So back to the patient flow example. I mean, rather than, I mean, I get maybe you would need some kind of policy or at least some kind of awareness across all your partners that we want to improve this issue. But could it be that you actually leave it to, some of these teams to come up with their own solution to that problem in their ward? Would that be possible?
I think that yes. Yes, no, and yes, I suppose. So I think that everybody, you're never going to get a straight answer out of me.
I really like these answers, so please continue. Yeah.
So I think that, yes. So, I mean, I think if you give someone a part of, well, this is part of a problem, and, excuse me, the answer or the solution sits within your ward, or because you're the people that will either make this happen or not. For you to come up with a process of, if we're going to give you a tick list or a process, and you look at it and you think, well, that's a bit wacky. You're making us do stuff that we don't need to do. Why are we doing that? And if those steps aren't serving the purpose of the patients, but are serving my ego or my processes or something else, the ward staff should have the authority to go, well, actually, the purpose is patients need to be discharged in a timely, safe, and appropriate manner. And that bit of the steps not going to work for us. But we'll do something ourselves. Yes, they have the authority to do that, and they should know that they have the authority. And some of our teams really get that, others not so.
Yes.
But each of those steps have got to link in together, haven't they? And there's got to be an overall understanding of what the goal is and what the achievement is.
Yeah, because I found obviously implementation during the worst, back in April and March of the pandemic, I've learned that a lot of teams were just left to their own devices to get, and they got a lot done very quickly. So I had one person, one consultant telling me, it would have taken us 2 weeks or a few months to get 15 more beds, but we were able to get them overnight because we just literally did it ourselves. We didn't have to write a case for it. Well, I just wanted to ask you, why is that not the norm? And I'm sure there's reasons.
So it should be more of the norm. I think that sometimes people will make a change which is really, really great for their service, but then it knocks out 3 or 4 other departments or parts of the process. And so there are greater consequences down the line.
I see. Yeah.
And so for instance, like doing the extra beds, or whether we got to increase critical care capacity, that stuff really happened very, very fast. But what we'd done in the first wave to manage that is we'd stopped so many services. So we had areas that they could move into. Money really wasn't an issue because we were getting money from central government to be able to get ventilators and equipment and pay staff, whatever, all those sort of things. Yeah. Now that's not normal times. But if we think about another example around doing telemedicine,
Oh yeah.
and the number of outpatient appointments that are now carried out through GPs or hospital staff on computer or just over the phone. That was in our organisation. That was minuscule from February and beforehand. When we couldn't get people to come into outpatient departments, it just grew enormous, because it was the only way in which people could see. Now, our IT colleagues had been talking about all these different opportunities, but we're the NHS, so we move really slowly. And then it was you'd need a subcommittee and a task and finish group and a govern and this, and we built up such a bureaucracy around things that what would have taken a couple of years to implement, necessity said, if we don't see these patients or don't have contact with them, they are going to end up in A&E because we've not managed them. And so we need to have some form of a contact. So we did stuff in a fortnight that would have taken a couple of years, and it worked. And those most skeptical of clinicians have said, even after about a month, I'm not going to stop doing this, even when everything goes back to normal, because this works. Why should we be dragging chronically ill people to a hospital to be charged for car parking, to wait for a long time in a waiting room, to sit in front of a doctor for 5 minutes and then go home, when we could just do something like this over online? Because I don't need to touch them. I don't need to physically examine them.
Mm-hmm.
I just need to talk to them to say, and so how are you feeling? How's your fatigue? How's that medication? And talk through everything you could have done across a desk. The necessity is the mother of invention, isn't it?
I think that's fantastic. Really glad you talked about bureaucracy as well, because that came up in a previous podcast. We felt, I was talking to this ICU consultant, the same one. But do you think there's a sweet spot? I mean, obviously, every problem is specific, every context specific. But is there a sweet spot between kind of too much bureaucracy, but also too much kind of So, and do you think we're still trying to find that?
Yeah, and I think that when we reflect back, because we've not really had chance to step back and think about what we've learned this year. But I think that when we do that, we will look at, so what went really well? And some of the stuff that we've done has been absolutely amazing. And we would never go back to as we were pre-pandemic.
Yeah.
And it worked really well because of we gave clinical staff the authority to make that change and tell us what you've done and is it working. And then we know pretty soon whether it's working, because patients would either tell us, or we'd know they're not being seen, or they'd turn up in the emergency department. So we gave a lot of authority to people who were knowledgeable about their service, who had that clinical background and understanding, and also had a lot of technical skill as well, and we gave that authority. Now, we put a governance process around it, but the primary force was people who ran a service, who knew their service and knew the needs of the patients, drove that change. And so I think we've said that for years, but we've never really lived it as much as we've done in this past 7, 8, 9 months.
So there may be some changes going forward, maybe keeping
absolutely, because you can't put that genie back in the bottle, can you? Or you shouldn't, because if you do, staff will go, well, it was all right in the pandemic. It was all right in 2020 when you wanted us to make quick and rapid change.
Yeah.
But in 2021, 22, you want us to sit through what?
Yeah.
That's never. And people will vote with their feet, won't they? And why do any of us want to sit through meetings when we don't have to? I mean, they're the most dull and boring things known to man.
Yes, I think that's very. A lot of people would agree. Yeah, a lot of people would agree.
And we all have to do it to some degree, because we do need that assurance. Yeah. We need to be able to say to our regulator or to our trust board that actually what we're doing, we're not just making changes willy-nilly, but there is a process that's running alongside, that's a check and balance, that we are safe and that we can demonstrate that safety and we can demonstrate that outcome.
Yeah.
But that's a much better way than it being this monolith of, do we change and then anybody can derail it because they're not playing ball or whatever, because the NHS is great for doing that.
David, Melia, thank you for your time on Essential Implementation. We hope to see you again.
Thank you very much.